Okay, good morning. I told the last group last time I heard something that good, it was at a funeral. Hope that doesn't mean anything. Let me go back up here. Okay, we're going to talk about heart disease in general, risk factors for heart disease. Oh gosh, I think I missed this. Okay. I've been in practice in Baton Rouge Cardiology Center 25 years. And can y'all hear me? Everybody can hear me? When I first came to town, there was two older guys in the group, and they were all hunched over, taking charts about this thick out of the door, could barely walk. And now that's me. I've been here that long that I'm doing that. But anyway, we're going to talk about heart disease. If you have any questions, just stop me at any time. Cardiovascular disease involves the heart and the blood vessels. Today we're going to talk about coronary artery disease specifically, but cardiovascular disease involves diseases of the heart, the vessels to the neck, the vessels to the leg, the vessels to the kidneys. It involves strokes. It involves valvular problems, congenital heart disease, things like that. But for the purpose of this thing, we're going to talk about blockages of the arteries around the heart and coronary artery disease. Okay, these are the different types of heart disease that we're all familiar with. First of all, let me say this. Why are we concerned about coronary artery disease, okay? This is the normal heart, okay? And if everybody can see... Yeah, how do we do that? My extent of computers is going to lsusports.net, so I'm not very good at this. There you go, good. I promise I didn't put these slides together. Okay, this is the normal heart, and this is why we're concerned about coronary disease, okay? The normal ventricle there, okay, pumps blood to all parts of the body, the heart, to, the brain, the kidneys, the lungs, the liver, the muscles, and blood comes from the lungs, okay? It gets oxygenated in the lungs. It comes back to the heart. It goes from that top chamber, the left atrium, into the left ventricle of the heart, and the left ventricle pumps blood to all parts of the body, the brain, the kidneys, the lungs. If it wasn't for oxygenated blood coming from this heart chamber, we couldn't survive, okay? Now, where does the heart muscle itself get its oxygen and get its blood? It cannot extract oxygen and blood out of the chamber, okay? So the heart muscle gets its blood supply from the coronary arteries, okay? And if you see right in the middle of the heart there on the top, there's an arrow going up as the blood shoots out. That's called the aorta, okay? And there are three small arteries coming off the aorta, which are called coronary arteries. Those arteries bring blood to the heart muscle itself, okay? And it supplies the heart itself with blood, just like the heart supplies the kidneys and the brain and the liver with blood. These coronary arteries supply the heart muscle itself with blood. And that's the arteries we're talking about when we talk about coronary artery disease. And when you develop coronary artery disease, you have certain symptoms, okay? Okay. These coronary arteries are small arteries. Believe it or not, most of them are smaller than a pencil. Most of them are much smaller than a pencil, but they're very, very important when they get blocked up. You see on the left there, you have a normal artery, and as we age and have risk factors, whether it be diabetes or hypertension, cholesterol, you develop blockages in these arteries, and the blockage can get worse. Now, this blockage is a plaque. Well, what is a plaque? It's calcium, it's blood products, it's cholesterol, it's lipids, it's fats. It's all the things that we don't do right that helps a plaque form in these arteries. As long as you have less than a 70% blockage, 75% blockage in these arteries, you usually don't have any symptoms, okay? And what happens as you develop blockage in these arteries, and these arteries get to be significant, or 70%, as you start exercising or start doing something, your heart starts beating faster, your heart needs more oxygen, your heart needs more blood, and because of a blockage there, your heart can't get the oxygen and blood that it needs. When your heart cannot get oxygen and blood it needs, you start having symptoms. This is what angina is, okay? Angina is simply blockage in the arteries, heart tries to exercise, heart tries to do too much, And because of the blockage, you can't get enough oxygen to your heart muscle, and you can have symptoms. What are these symptoms? When you start doing too much, you get chest pain, you get short of breath, you get easily fatigued, you get dizzy, you get lightheaded when you exercise, you may get real sweaty when you exercise. These are symptoms of angina, and they're a clue that something's not right, okay? Just because you have angina doesn't mean you've had a heart attack. And I wanted to tell you, if anybody has any questions, just stop me along the way, okay? So as your blockage gets worse, you have more and more symptoms. Then, if you're unfortunately may be at risk of having a heart attack. Now, what a heart attack is, if you look to the far right, these plaques hopefully are stable, but sometimes they're unstable, and the plaque will rupture. And what happens when the plaque ruptures is blood gets released into the artery, platelets, which are clotting factors, gets released into the artery, and this blood clot, because of the platelets clumping together and all these blood products clumping together, causes the artery to block off completely. When that artery blocks off completely, this is a heart attack, okay? And at that point, your heart muscle, that part of the heart muscle is not getting blood, it's not getting oxygen. When you're not getting blood and oxygen to the heart muscle, you're at risk of having a heart attack. It's very important, if you can get to the doctor, get to someone within 3 hours, most of this can be reversed, okay, with blood thinners and blood clot, with clotting agents and thrombolytic clot busters, and intervention going in, opening up the artery in the cath lab. If you can do this within 3 hours, you can salvage some heart muscle. Obviously, the sooner the better. 15, 20 minutes would be great, 30 minutes would be great, but most people's 30, 35 minutes before they decide to go to the emergency room. But that still gives us plenty of time to do what we need to do. If you've gotten past 6 hours, chances are the damage is done, and not a whole lot can be done about it, about the heart muscle damage. Now, why is this important? And generally, for some reason, women tend to wait longer before they go to the emergency room than men, and that's why most women, especially older women, when they have heart attacks, are more likely to die from their heart attack, more likely to have significant problems. It may be because we realize now that women have different symptoms than men, but I think in general men tend to wait longer before they go to the emergency room or go to the hospital. Now, this is the issue with having a heart attack. You see the normal heart, and you see this is a damaged heart. What happens when you have irreversible damage to your heart muscle is the heart enlarges. As the heart enlarges, it doesn't pump as good of blood, okay? When we do catheterizations, we like to measure what's called the ejection fraction, okay? And what the ejection fraction means is how much blood is being pumped out by that ventricle every time the heart pumps, okay? And usually anything over 50% is normal. So if your ejection fraction is 50%, which means 50% of the blood in that heart muscle gets pumped out, that's normal. You should have no symptoms from that. As you damage your heart muscle, your heart gets enlarged, the heart is not able to pump as effectively, and you can see here part of that blood is left in the ventricle, and the ejection fraction drops. If it drops to 45, 42, you're generally okay. When you start getting in the 30s and 20s, you're going to have significant symptoms, okay? And what happens here, you see the normal on the left, the abnormal on the right. As this blood is not pumped out of the ventricle, it's got to go somewhere. It backs up into the lungs. When it backs up into the lungs, it causes shortness of breath, and that's congestive heart failure, okay? Now, not all heart attacks result in congestive heart failure, okay? The damage may be minimal, the damage may be reversible with whatever we do, and it may be in a good area, a small artery that doesn't cause a whole lot of damage. But major heart attacks, certainly several of them, you're at big risk of having congestive heart failure. There are several causes of congestive heart failure. Coronary disease is number one, okay? That's why it's important to prevent heart attacks, and the best treatment for congestive heart failure is to prevent the heart attack. Once heart muscle is damaged and you've gone more than 6 hours, the damage is done, you may do okay with that heart attack, but you're at risk of developing heart failure later if you have some other problem. So the best treatment of congestive heart failure is to prevent coronary disease. Okay? Now, let's go back to risk factors for coronary artery disease. Okay, the most, I'm going the other way I think, there are preventable and unpreventable causes, risk factors for coronary disease, okay? These are the controllable risk factors. High blood pressure is treatable. Diabetes is treatable. Cholesterol issues are treatable. You can stop smoking. Obesity is treatable. Inactivity is treatable. All these things we can treat. The most important thing you can do to prevent coronary disease if you smoke is to stop smoking. Clearly, smoking has the most deleterious effect developing coronary disease than any other risk factor there is, okay? They're uncontrollable risk factors. You either have a family history or you don't. You can't do anything about your age, and certain races have a higher incidence of coronary disease. You can't keep from getting older. You can't pick your parents, at least not yet. So there's nothing you can do about having a family history. Now, when we talk about family history for women, it's much more, the history of your mother and sisters is much more important than your history of your dad. Not if if your dad had a heart attack in the 50s, that's concerning, but if your mom had a heart attack in the 50s or a sister had a heart attack in the 50s, that's a pretty significant risk factor. A mother who had a heart attack in 82 or a dad who had a heart attack at 90 is not a family history of coronary disease. I mean, that's, we're talking about early development of coronary disease in people in their 50s and 40s, 50s, and early 60s, okay? What is that? Men, it's much more, in guys that I see, I'm more concerned about, obviously if the mom had a heart attack at 40, but guys usually follow their dads, okay? And a family history in a dad who was 40s or 50s is much more important. Like I say, if the dad had a heart attack when he was 92 and not really considered coronary disease, it's not good if a guy's mom had a heart attack in her 40s or 50s, but it's much more, I look for women, I look to sisters and mothers. For guys, I look to dads and brothers. It's just the way it works, unfortunately. Okay. 82% of women of people who die from coronary disease are 65 and older. And women who have heart attacks are more likely to die from the heart attack than men. I think part of this is because the medical community is finally realizing that women have different symptoms than men do. And I think we're realizing that women have heart attacks, okay? I think medical community has done a poor job of educating women about heart attack symptoms are not the same as men. They can be the same, but they're not always the same. And I think women probably tend to be a little bit tougher. Most guys are probably wimps. And I think women tend to be a little bit tougher and wait out symptoms a lot longer than guys do. So I think that's why when women get to the hospitals, they've waited a little bit longer than they should have waited. Okay, let's talk about risk factors for coronary disease. One of the most important is cholesterol. Cholesterol can be treated, and let me say this before I talk about that. You need to find a doctor you trust. You need to find someone that treats your blood pressure, your cholesterol, your diabetes. It's not good to have two different doctors treating your blood pressure or your cholesterol. There's a rhyme and reason for what we do, how we treat cholesterol, how we treat blood pressure. There's more than one medicine to use, especially with blood pressure. Certain doctors like to use certain medicines that work for them. And if that doesn't work, he's going to do something different. So it's just not good to have 2 or 3 different doctors treating your blood pressure, treating your cholesterol, treating your diabetes. You need to have one doctor that you like and stick with him. I think it's okay if you're low risk. I think if you're, in your 40s or 50s and your blood pressure is good, your cholesterol is good, your sugar is good, then I think your GP is very good at doing that. No, not necessarily. I think if your cholesterol's, well, let me say this. I think if your cholesterol's high and you're in your 40s or 50s and your mom had problems in her 40s and 50s, you probably should go to a specialist to start doing some type of treadmill testing. Now, I'll say this. Most of the family practice guys and the internal medicine guys in Baton Rouge are pretty good about that. But I don't think there's anything wrong with those guys treating the blood pressure, cholesterol, because usually they refer when they need to. If you have several risk factors in your 40s, you probably ought to have a periodic treadmill because a lot of this is preventable, okay? But if you have low risk, family doctor, internal medicine, those guys are good. They do what they need to do. Okay, cholesterol is treatable. Most people eat way too much fats and junk, all the good stuff that raises your cholesterol. Anytime you have a cholesterol, you should have a good cholesterol and a bad cholesterol. Good cholesterol is HDL, bad cholesterol is LDL. As bad as a high LDL is, a good HDL is just as protective. Okay, so the HDL prevents heart attacks. The bad cholesterol causes heart attacks. So you should never just have a cholesterol and come in and say, my cholesterol is 250. Why isn't my doctor treating that for me? Because if your cholesterol is 250 and your good cholesterol is 90, which is supposed to be 40, then it doesn't need to be treated. Okay, so ratio, and I'm not concerned about what that ratio number is, but the absolute number of HDL is just as important as the absolute number of LDL. Okay? Yes? Mm-hmm. No. Well, yeah. Yeah. Okay. Okay. I would bet that because I've seen, young women who don't have risk for, I would bet your HDL is probably, what was your total cholesterol? Okay. I would bet your HDL is probably 90, which is excellent, okay? And for some women, for some reason, women have higher good cholesterols than men in general. So just knowing what I've done for 25 years and seeing a lot of patients like you, I suspect all yours is good cholesterol. Now, I can't guarantee that. You probably ought to have it checked, but I think you'll be surprised how good your good cholesterol is. Okay? So we like to see good cholesterols over 40, bad cholesterols less than 90. If you've had a heart attack, or if you've got coronary disease, if you had a heart catheterization and you have blockages and you have already had a heart attack, it doesn't matter what your cholesterol is, you need to be treated, okay? Because, I see people that have a heart attack and I want to put them on a statin medicine for cholesterol. Well, my cholesterol is normal. Whatever your cholesterol is, it's not good enough, okay, to prevent coronary disease. So if you've already got coronary disease by catheterization, you've already had a heart attack, you need to be on statin medication. And the statins are clearly the best medicine for treating cholesterol. And we'll talk about, well, I'll go ahead and mention it now. I see a lot of people who get concerned about taking statins because of the liver enzyme problems and taking blood pressure medicine because of certain problems. I can tell you this, the risk with the medicines we have today, the risk of taking a statin or a blood pressure medicine is much less than the risk of having a cholesterol 260 or a blood pressure 160. The risk of taking the medicine is less than the risk of not taking the medicine. Okay? I've never seen irreversible liver damage or muscle damage from taking a cholesterol medicine. Never seen it. I've seen medicines that needed to be stopped. The enzymes always go back to normal. But I've never seen people lose a liver from the statin. Yes, ma'am. I think it's good for certain people. I think it's good, for instance, she just asked a question about her. If she has no risk factors and you do a cholesterol that's borderline, then I think it's good for that. Whether you decide to treat this patient or not with no risk factors in their 40s, you're going to commit them to a cholesterol medicine for another 30, 40 years. I think it's good for that, but it's not good for everybody. Some people clearly need to be treated, and I think that test, like everything else, can be overused. Not everybody needs that test. If you've had a heart attack and you've got coronary disease, your cholesterol needs to be treated. So that's good for people that are low risk, that have cholesterols that might be a little bit high. The bad cholesterol is a little bit high. You do that profile and it comes back pretty good. Then you decide not to treat that patient. I'll be honest with you, I do that test about once a month. I just don't use it very often because usually it's clear. Yes, ma'am? Well, like I was telling her, I would bet your good cholesterol is very high, okay? If your bad cholesterol was 90, which is okay, and your good cholesterol, which needs to be over 40, was 90, then you don't need to be treated. The total really doesn't mean anything, okay? Okay, cholesterol is treatable if you follow your diet, exercise. And I'll say this too, I've seen people who smoke and diabetic and significantly overweight and didn't do anything right that had no coronary disease. And I've seen people who did everything right and had coronary disease. The bottom line is this: if you do what you're supposed to do, your chances are much better than of not having disease. Some people get lucky, some people smoke forever and they do fine. But if you do what you're supposed to do, chances are you're going to have a better outcome than if you don't do what you're supposed to do, statistically. Okay, blood pressure, very important. Risk factor for coronary disease. It's treatable. The drugs we have today are usually once a day. They're low risk. They're low side effects. There's rarely a reason to take a medicine 2 or 3 times a day anymore. The medicine we have today is simply too good. There's hundreds of medicines that we can use, 6 or 7 or 8 different types of medicines. But medicine is blood pressure is very, very treatable. 120/80 is a great blood pressure if you're a 19-year-old girl in college, but not everybody's going to have 120/80, okay? I would suspect that half of you in this room, if your blood pressure is 120/80, you'd feel terrible. The older you get, the stiffer your arteries get. It takes more blood pressure to perfuse your brain, your kidneys, your liver, and 135, 140 is acceptable for many people. Matter of fact, I would say I don't have many people at 120/80 unless they're a young girl coming in for palpitations or something. I don't have many people whose blood pressure is 120 or more. These are guidelines made by big centers that usually don't treat patients. And if you get everybody's blood pressure down to 120/80, half the people aren't going to be able to walk because their blood pressure is going to be too low for them. Now, don't walk over here saying Cefalu said everybody's blood pressure needs to be 150. But I think it's acceptable in many people to have blood pressures of 135, 140 if they're older and they need that blood pressure for their perfusion of the kidneys, perfusion of the brain. Most people in here, just looking at the ages, don't have blood pressures of 120. We'll never have blood pressures of 120 again. 150 is not good, but 120 is not going to work either. Clearly, blood pressure is a risk factor for developing plaques in these arteries, just as cholesterol is. Glucose is very important. There's too many diabetes. We eat too much sweets, too much chocolate, too much cake, all the good stuff. We all eat too much salt. We all eat too much junk food. And diabetes is a major risk factor for development of coronary disease. I would say that short of smoking, it's the most important risk factor besides cholesterol, besides high blood pressure. I personally believe diabetes is a bigger risk factor than the other two. They're all important, okay? Blood glucose is easy to treat. Find a doctor, endocrinologist, internist that's treatable. It's easy to treat. Exercise lowers your blood glucose. There's many complications of diabetes besides development of coronary disease. Eye problems, retinal problems, kidney disease. It contributes to high blood pressure, paresthesias in the feet, neuropathies in your feet. So there's nothing good about diabetes, but it's treatable. Everything we're talking about is treatable, okay? Another risk factor for development of coronary disease is physical inactivity. Way too many people do not do some type of exercise, okay? These are the numbers: 52% for black females, 38% for white females, probably higher than men, or it is higher than men. And not enough people exercise. What does exercise do? Lowers your blood pressure, lowers your cholesterol, lowers your blood pressure, it raises your good cholesterol, it lowers your sugar, it lowers your weight, it makes you feel better. And there's clearly exercise is beneficial as far as lowering risk factors. Now, people ask me all the time, what should my heart rate be? I don't know. I don't know what your heart rate should be. But I do know if you get out there and walk for 30 minutes, 4 or 5 times a week, and you get your heart rate up, that's helping your heart, okay? If you're running marathons and want to train for a marathon, you need to talk to somebody about what your heart rate needs to be to get there. I don't know that. But I can tell you that if you exercise, if you walk, or bicycle, or treadmill, or swim, anything you do to get your heart rate up 30, 35 minutes at a time is helping your heart. It's been shown statistically. And I would recommend, 3 to 4 times a day, at least 30 minutes. If you want to do every day, it's not going to hurt you. One of the things that I see, particularly in men, is they didn't take care of themselves. They come in at 55 or 50, and they're significantly overweight, and they want to start exercising. Then they start exercising, and then the back hurts, the knees hurt, the legs hurt, the feet hurt, and they've gotten to the point where they can't. And it's a problem, because then what can you do? Swimming, not everybody has access to a pool, but it's gotten to be a problem where they've waited too late to get the weight off, and then they have significant physical problems because of that. So they're stuck doing nothing. Okay, obesity, clearly there are way too many good studies showing that obesity elevates your blood sugar, your blood pressure, your cholesterol, can precipitate diabetes, lead to diabetes. About 69 million women are overweight, and 37 million are considered obese, which I think is 35% overweight. And these clearly increase the risk of developing heart disease. Not only, there are studies to show that not only does obesity raise your blood pressure, your glucose, and all those things contribute to heart disease, but just being obese itself raises the incidence, whatever it does to the other factors. Just being obese itself raises the incidence of heart disease. Okay? Now, smoking, besides the diabetes I mentioned, the most important thing you can do to lower your risk of heart disease is to quit smoking. Okay? It's the most correctable, treatable risk factor that we have in women for development of coronary disease. Okay? Within 1 to 2 years of quitting smoking, your risk of coronary disease goes down significantly. Your smoker's cough goes away. You can be much more physically active. Besides causing coronary disease, smoking causes emphysema. And basically what emphysema is scarred lungs. And once you get scarred lungs, it's hard to treat that. It's hard to reverse that. Okay. What can you do to prevent heart disease? Eat right, eat less sodium. Probably, and I mentioned to the other group, probably most Americans, before they get serious about this, eat enough salt every morning than they need for a couple of days. Okay? Because if you look at the packaged foods and the things that we eat, you're allowed about 1,500, 2,000 milligrams of sodium a day. And most people, especially guys, will take 3,000, 3,500 at one meal without a whole lot of problem. But we eat too much salt. We eat way too much sweets and sugars and fried foods and fatty foods and greasy foods. And the diet, a good diet is not hard. It really isn't. Stay away from fried foods, stay away from red meats, stay away from sweets, fish, turkey, chicken, vegetables, fruits. It's not difficult. It's not hard to understand. Sometimes it's difficult to do. But that doesn't mean you can't ever eat red meat. You eat it in moderation, eat fried foods, once every 10 to 12 days is not going to hurt you. Most of the time when you get treated for your cholesterol, you get put on a medicine or something, your doctor will not check your cholesterol for 6 weeks, 2 months, 3 months sometimes, because it takes that long for your cholesterol to come down. My point is, just because you go out to eat one night and eat some fried fish or whatever, your cholesterol is not going to jump up sky high and cause a heart attack. It doesn't work like that, okay? You do that every night, you're going to have a problem. But once every now and then to cheat, to eat fried foods, whatever you want to do, it's not going to kill you as long as you do other things right and do the things you're supposed to do, okay? Most of this heart disease is preventable by treating these risk factors, but unfortunately, over half the people that have heart attacks don't have symptoms, okay, before the heart attack. I told you earlier about when you start developing a blockage, you start exerting yourself, you get chest pain, short of breath, sweaty, fatigue. That is angina, okay? And anytime you start feeling that, you should see a physician. Unfortunately, over half the people that have heart attacks don't have any symptoms, okay? The first symptom that they have is severe pain in their chest, short of breath. For women, it can be different, and let me talk about that for a second. The signs of a heart attack for women Most men get it in the center of the chest, into the throat. Women can have it in the upper back, the arms, the upper neck. They can get suddenly short of breath, suddenly sweaty, sudden lightheadedness, and even all of a sudden suddenly fatigued. That can be the symptoms that women have, okay? If you have any of those symptoms, you need to get to the hospital, quickly. 15, 20 minutes to do yourself some good. Angina is a warning sign, but half the people do not have angina. If you do have risk factors for coronary disease, you're diabetic, you have cholesterol issues, you have blood pressure issues in your 40s, you have a family history, you should find somebody and do a treadmill, because treadmills can pick up these blockages, not all the time, but a lot of the times they can pick up these blockages. You can have treatment, you can have stents done, you can have things to improve yourself. If everybody had symptoms before the heart attack, it would make it easy, but they don't, okay? So, the difference in women and men as far as heart attack symptoms are clear, and women don't always have the sudden tightness in the center of the chest. They can get the dizziness, the nausea, the sweating. If anything lasts suddenly more than 15 to 20 minutes, you need to go to the emergency room, okay? Now, let me just show you some of the things we do in the cath lab. I don't think this slide shows up that good, but this is when we do a heart catheterization, okay? We put a catheter inside the ventricle to measure the ejection fraction. So if you can't appreciate it, basically what that is dye being injected into the heart muscle to look at the heart muscle. But this is what I really want to show you. Most people have 3 coronary arteries, one on the back, one on the front, one on the side. This is the artery in the back, and you can see the dye being injected into the artery. There's no blockages, it's nice and smooth. This is the arteries on the front and the side. The one on the top is the left anterior descending. That is clearly the most important artery. Not that all of them are not important. That's clearly the most important artery. Those are 2 normal arteries. This can be done if you get to the hospital in time. This is acute. This is a heart attack, a myocardial infarction, the plaque ruptured, and caused total occlusion of the artery, okay, because of the clot, the platelets and all that. The artery blocked off completely, patient's having a heart attack. You get to the catheterization lab quick enough, and you can put some stents in, and within 3 hours, if you get that thing open, you prevent a lot of damage, okay? Now, the same thing can be done with thrombolytics, but if you're in Baton Rouge with the facilities that we have at any of the hospitals, you get to the emergency room, the state of the art is going to be to go to the catheterization lab. If there's no contraindications, if there's no reason you can't go to the catheterization lab, if you come in with a heart attack, you can be taken to the lab, and this will be attempted. If you're in an outlying area that doesn't have these facilities, you can get thrombolytics and clot busters, and as long as those things open up this artery and prevent a heart attack, then you can always come back in and do a stent or fix the blockage later, okay? So I can't tell you enough how important it is to monitor your symptoms, monitor anything that changes in you. If you're exercising and all of a sudden you start having chest pain or jaw pain when you exercise, or throat pain when you exercise, or more short of breath than you normally should be, those are all important signs. You should see someone. Yes, ma'am. I recommend taking a baby aspirin if you have known blockages, okay, or if you're at high risk. You have high blood pressure, you have high cholesterol, you have a sister in her 50s that had heart problems, I recommend taking baby aspirin. I do put people on full aspirin in certain instances for a short period of time. I do not recommend taking a full aspirin as a preventative. This long term, that can cause some problems too. So baby aspirin, if you have risk factors and you definitely have blockage, I would take it. Any other questions?
I have a question. If you are aspirin intolerant, it tears up your stomach to take an aspirin. What alternatives are there?
Well, there are coated aspirins that you could. You can't.
Even with the coated aspirin, sometimes that's not
Yeah. Okay. There are alternatives you can take if you've had a stent. Or if your coronary disease is significant, you can take Plavix and Effient and things like that. If you're just taking it as a preventative and you can't take aspirin, I wouldn't take anything, because the risk of taking those other medicines, those are strong medicines, and if you have to have them, that's great, and they can be monitored. But the only thing I would recommend, as a preventative is aspirin. You can't take aspirin. I would take fish oils if you're at high risk. Fish oils, the benefits of fish oils is aspirin is an anti-inflammatory, prevents the platelets. Fish oils have been shown now lately, and the risk of taking fish oils is ridiculously low. Some people get a little upset stomach from it, but I'm not so sure everybody shouldn't be taking fish oils because the benefits from fish oils are pretty dramatic, and they have been shown to prevent heart attacks, shown to lower your cholesterol, and be a pretty good preventative. No, there's no such thing as anything that's going to prevent everything. If you do what you're supposed to do, eat right, exercise, follow everything right, that's the best you can do. Okay? Yes, ma'am?
Would you repeat what you said about 120
Blood pressure. Okay. The recommendations for blood pressure by the National Hypertension, whoever does these things that doesn't treat patients, says that everybody should be 120 over 80. But I can tell you that any woman in her 40s and 50s and certainly 60s is going to feel terrible with a blood pressure of 120. Okay? The older you get, the stiffer your arteries get, the more blood pressure it takes to perfuse your brain, your kidneys, your liver. And if you got every woman or every person's blood pressure to 120 over 80, half of them will be passed out on the sidewalk. Okay? Because you can't, that's great for a 20-year-old girl, 25-year-old girl, but as you get into your 40s and 50s and 60s, 120 is not going to get it done. I have a lot of older men, that I allow 140, even 145. If they feel better, you're not going to have a heart attack at 140. You're not going to have a stroke at 140. I think the difference between 140 and 120, if you feel okay, I think if you live to be 150, it might make a difference in developing heart disease. But personally, I think that very few people who come to see a cardiologist, I don't see, 20-year-old people that often. I see some with palpitations, but most of the people I see are in their 40s and 50s. And rarely do I see people that come to see me, they can tolerate a blood pressure of 120 over 70. If they can, that's great. But most people can't. Okay? Anything else? Yes, ma'am? 120? Well, if you're 120 over 70, that's fine. If you feel okay. But I'm saying that some people come in with 160s, 165 needs to be treated, and you get them down to 140 and they still feel okay. Well, the lower you can tolerate, I like your blood pressure as low as you can get if you feel okay. If you get it to 140, you feel okay, I'm going to try to push it to 120. If you come in at 120, say, I just feel terrible, then we're going back to 140. Okay? Not everybody can tolerate a blood pressure of 120 over 70. And it's just not going to happen. Yes, ma'am? No, I think you should. I think the oils are probably not the way to go. But omega-3 fish oils, every drugstore has omega-3 fish oils. And matter of fact, I take 3 a day, okay? I would recommend most people take 3 a day. Fish oils are so good. There's a lot of studies on fish oils. We now have a medicine called Lovaza that's just super concentrated fish oil that we give, and each one of those is equivalent to 4 fish oils. It's a prescription medicine. And so fish oils are probably fairly cheap. I don't know how much they cost, but I think everybody ought to be taking it. There's a lot of good studies on preventing inflammation, arthritis, heart disease. I think everybody ought to be taking a couple of fish oils a day. Yes, ma'am? It's omega-3 fish oils, omega-3 fish oils. And I think some of them are called super omega-3 fish oils. And some people are starting to push the 6s now, but I think omega-3s are still most important. Okay. Anything else? Yes, ma'am?
I was kind of impressed with you talk about 120 over 80 blood pressure. I'm 70 years old. Most of the time mine is like 120, 70, 80, maybe 90. That's it. And I have some younger nieces that say, I keep up with them working hard.
Yeah.
So,
Well, that's good.
wouldn't be trying to raise
No. Oh, no. See, yeah. No. If you can tolerate 120 over 70, that's great. But most people that your age are not going to be able to do that, okay? I don't want everybody's blood pressure 150, okay? I will get it as low as I can until they start feeling bad, then I'll back off. And then if that's 130, 140 for them, that's fine. If it's with 90, that would be great if you felt okay, okay? Anything else? Yes, ma'am? Okay. Let me say this. Most people, I'm not familiar with that. The amount of calcium you take in, you know, I've heard some people say to me, you know, I got calcium in my arteries, should I not be eating calcium? That's got nothing to do with it. The amount of calcium you eat has nothing to do with calcium in your arteries, okay? Most people that have blockages don't have calcium in the arteries. And most people that have calcium don't have blockages, okay? If you see calcium in the arteries, it's an indication that you need to treat the blood pressure, the cholesterol, because that's early disease, okay? So you need to be more aggressive treating the sugar, the blood pressure, the cholesterol. But most of the people that I send to surgery or do a stent on that have blockages, I don't see any calcium. And most of the people that see all kind of calcium have very little blockage. I think there's a weak indicator between calcium in the arteries and blockage. I think it's very weak. Matter of fact, we have a cardiac CT scan that came out about 8 years ago, and that was supposed to be the end all. We could measure all this calcium, and it just hadn't worked like that. You know, we measure the calcium, the blockage. In my experience, when I do a heart catheterization, it's not what the scan showed. I just don't think they're very good. The best thing you can do, besides the risk factors, I think serial treadmills are as good as anything, because if your treadmill changes from 1 year to the next, that's significant. Or from 1 year to 3 years later, that's significant. Yes, ma'am? No. That's got nothing to do, a leak, a valve problem has got nothing to do with coronary disease, okay? We can do ultrasounds of the heart, okay? And now we can do Doppler evaluations of the heart, same thing they get you with when they do the speed guns, okay? We can do Doppler evaluations of the heart, and now we're finding that probably half the people that we do just regular ultrasounds on have some type of little small leakage. Doesn't mean anything because these things are too sensitive. Now, I suspect what you're talking about is a little more significant, but what I've seen people go a long time with leaking valves, as long as it's not severe, before they have to have a problem. Now, if the leakage gets too severe, it's an indication to replace the valve. But I've been following people for 20, 25 years with the same leaky valve they've had 25 years ago, and it hadn't gotten any worse. Okay?
Question.
Yes, ma'am?
Just a line where I received your brochure
Uh-huh.
that said to me that the calcium for heart scan is very different.
Mm-hmm.
Matter of fact, I was told it was a very good thing to do.
Mhm.
And I was going from what you said to
Mhm.
me. If I were to do either between the vascular strain
Mhm.
of a calcium heart scan,
Mhm.
just for your expertise, which one is something I ought to be more greater than?
The heart screen. Now, I'm not saying that calcium is not important, because you have calcium, you need to treat your cholesterol, your blood pressure, but it doesn't mean you have blockage. It needs to be alert you to the fact that you need to treat some things, watch your blood pressure, watch your sugar, watch your cholesterol, exercise. It doesn't mean you have a heart problem. Okay? Okay, thank you. Is that it?